All right, and we're back. Some more Pearl Jam. Um, Looking more at the hemolytic anemias over here on this side of your chart. So let's go through the classification. So one of the primary ways you can classify is intravascular versus extravascular on the site of hemolysis. You can also classify based on what the disorder is. So is it enzyme disorder, membrane defect, microangiopathic, macroangiopathic, more autoimmune? And these are all going to be kind of a mix of intravascular, extravascular, but it's just other ways to think about it in terms of categories. You can also have just kind of infectious, toxic, kind of catch-all stuff. Another thing down here that I think I saw in a UWorld question at one point was bongo drummers can get hemolytic anemia just from kind of repetitive trauma. It's also, get March hemoglobinuria. So long repetitive marchers, marathon runners, that sort of thing. But a lot of different categories, and we'll try to go through these. In terms of intravascular versus extravascular, so I'm not going to read this text to you. You can go back and read it. But for intravascular, so inside the blood vessels, that's when you get your microangiopathic anemias, anything that's fixing complement and causing activation of the complement cascade can be intravascular. You get schistocytes with your microangiopathic and macroangiopathic disease, so shear forces of the red blood cells, versus extravascular as the spleen is processing these as extravascular reticular endothelial system. It takes bites out of the membrane and gradually shrinks these cells down, and they turn into spherocytes. So remember that you can get spherocytes not just with HS, but with any sort of extravascular hemolysis. Haptoglobin, so the haptoglobin binds free hemoglobin pretty much instantaneously in the blood. You don't get hemoglobin floating around in the blood. So in intravascular hemolysis with a lot of hemoglobin released, your haptoglobin is going to be less than 8. It's basically going to be 0. You can get mild decreases in extravascular hemolysis, but it's not going to be 0 like intravascular. So once haptoglobin binds to heme, once that gets overwhelmed, hemoglobin is filtered and reabsorbed in the kidney. Once that capacity is overwhelmed, you can get hemoglobin in the urine. And remember, this doesn't really happen in extravascular because all of the hemoglobin is being processed and broken down in the spleen. The Coombs test, your DAT, is usually negative in intravascular because it's usually more of a microangiopathic process. Extravascular tends to be your autoimmune anemias. LDH is going to be up in both. It's going to be more up in intravascular, but don't let the LDH throw you off too much. So here's the workup I like to go through, and this is just a way to think about hemolytic anemias, kind of where to go in the labs when you're thinking through a case. So anemia, normocytic or macrocytic. Remember, reticulocytosis with severe hemolytic anemia, the reticulocytes are a bit bigger, so it can cause actually macrocytic anemia. So you get your labs, you think, okay, this is hemolytic, high bili, high LDH, hemolytic anemia. Do a peripheral smear. So if you see like sickle cells, okay, it's sickle cells. If you see over here, if you see schistocytes, then you're thinking, is this a microangiopathic process? Do they have low platelets? Something like HELP or TTP. These can be very dangerous disorders, right? So these are sick people. You want to identify them right away. You're not going to do a Coombs test probably on someone you think has TTP, right? You want to diagnose them right away. You want to get them help fast. You might end up doing a DAT, but this is something you want to identify right away. Do they have low platelets? Do they have renal disease, other stuff going on? If they have schistocytes on the smear, you want to be aware of that. If they don't, if you maybe see some spherocytes, you see some something else, then go ahead and do the Coombs test, your DAT. Now, if that is negative, if it's not it's not immune mediated at all, then look to see what else you see. Is there spherocytes? Is this more of a extravascular process? It could be hereditary spherocytosis. If you see a lot of spherocytes, it could be more of a enzyme defects, so PKD, G6PD, can be some sort of infection, Clostridium, babesiosis, malaria, stuff like that. You're going to kind of want to use your other clues to diagnose these. These are diagnosed with more enzyme tests. HS you can diagnose with osmotic fragility. We're going to go through each of these disorders. But once you get a positive DAT, you want to be able to see, okay, what's in IgG? You're thinking more warm autoimmune. Complement only, you can think of cold agglutinins. To distinguish between paroxysmal cold and cold autoimmune, you want to do a Donnelly-Steiner test. But that's kind of how to think through these. So let's go on to sickle cell. So if you get the smear, you see sickle cells. Usually these people are diagnosed by newborn screen. But I'm going to let you guys read most of this. You guys know sickle cell disease. The big thing is going to be how the complications from sickle cell, acute chest syndrome, bilateral infiltrates. Can be very morbid for the sickle cell population. It mimics kind of a pneumonia. It's not always an infectious process in acute chest, but you want to treat them right away with transfusion and get a hypersplenic crisis, which requires splenectomy. Eventually, in sickle cell patients, this spleen kind of infarcts away. You can get dactylitis, so the swelling in the fingers. Priapism is a big concern for younger males. And that could be really dangerous as well. Stroke, renal papillary necrosis. That's also something to remember. If people with just sickle cell trait with no symptoms of the disease can also get renal papillary necrosis, they can get some hemoglobinuria. You'll get athletes who go up to the higher elevations or stuff like that, and they start peeing brown, and they don't know why. It's because they have sickle cell trait and they never had symptoms before. Osteomyelitis is another thing. You can also get bone infarction, but differentiating that from osteomyelitis is important. And salmonella is kind of the classic association. So treatment of sickle cell disease, hydroxyurea increases hemoglobin F, so you get less of those damaged beta chains and you get more gamma chains. Folate supplements are important because sickle cell patients have such rapid turnover of red blood cells that you end up having low folate levels. You have to transfuse them if they have acute chest syndrome or if they're at high risk for stroke. Treat them with penicillin at a young age. Oftentimes they get treated with penicillin even longer than this, but at least through age 6 to prevent infection. And here's your mnemonic for encapsulated organisms that you want to vaccinate, of course, against Hib, meningitis, S. pneumo, but really watch out for these organisms in these patients. So, WEHA, warm autoimmune, that is going to be looking at this chain, positive DAT, IgG, plus or minus complement. So, it's going to be a more severe hemolytic anemia. It's going to be chronic. People can feel very weak. You get this extravascular hemolysis because IgG doesn't really cause good complement activation, but it does kind of mark the red blood cells, and they are taken out in the spleen. It's associated with chronic lymphocytic leukemia, which we'll learn about, lupus, certain drugs. And again, the DAT is positive for IgG. So more severe anemia, IgG, think warm autoimmune. Cold agglutinin disease, CAD, so that's IgM mediated, so you'll get a positive DAT, but it'll be to complement. Because what happens is the IgM antibody binds red blood cells at cold temperatures, but complement is really only activated at warm temps. So the IgM binds, kind of your extremities, areas where the blood's a little more cold, and then it activates complement, and you get this intravascular hemolysis. So you can get a monoclonal IgM if you do an actual electrophoresis, like an SPEP. If you do a cold agglutinin titer as another lab you can send out. It's associated with kind of the M's, IgM, mycoplasma, mono, and it tends to be also more mild and is not as severe anemia as your warm autoimmune. PNH, so that's kind of a weird Coombs negative disorder. It's actually a disorder of the GPI anchor that holds these proteins that prevent complement activation. So you lose the anchor, you lose these proteins that prevent complement activation, you get this kind of spontaneous formation of the membrane attack complex, causing intravascular hemolysis. So it happens at night because you breathe less at night, your respiratory drive kind of drops a little bit, you get a little bit of acidosis, and complement needs to be activated a little bit more. It's also associated key things with pancytopenia and venous thrombosis due to kind of this complement activation cascade. Diagnose it with flow cytometry and treat with eculizumab, which is an anti-CD5, kind of blocks activation of the CD5 in the membrane attack complex. So TTP, so this is your microangiopathic hemolytic anemia that's caused by, you have this enzyme called Adams TS13 that normally cleaves von Willebrand factor, which you guys will learn about more in the clotting and platelet disorders later. But you get these big von Willebrand factor multimers. They kind of produce this platelet adhesion, cause this clotting cascade, and because you have these clots in all these small vessels, it shears the red blood cells. You get schistocytes. You get intravascular hemolysis, and it can be very severe, very deadly. The classic pentad, it's actually very, very rare to see all of these things together. But once you get a couple of them, if you have a microangiopathic hemolytic anemia, thrombocytopenia, you want to be thinking about it, even if they don't have this other stuff. But you can also get neurological symptoms, like stroke, confusion, they're a little bit altered, renal dysfunction, and a fever. You want to really be thinking about TTP, thinking about transfusion. HUS, another microangiopathic hemolytic anemia. You can have it associated with diarrhea or not. Usually it is associated with diarrhea. The D- is very rare. I wouldn't worry too much about it. So the D+ is the classic 0157 H7 E. coli. It's Coombs negative. You also get the thrombocytopenia. Differentiate it from DIC by the normal clotting times, PTT and PT. Same for TTP. You also don't get the coagulopathy, and it's more associated with renal insufficiency than TTP is. So moving on to the non-microangiopathic, you have hereditary spherocytosis. Key things to remember: autosomal dominant transmission. It's a defect of the membrane proteins, and so you get these fragile red blood cells that cause kind of a mix of extravascular and intravascular hemolysis. You get a splenomegaly. The test you want to do, you see an increased mean cell hemoglobin concentration because these have, membrane is incompletely formed. They have more hemoglobin on average, and they're very fragile. So you can do an osmotic fragility, kind of the classic test. That'll be positive with boards, and you can treat it with a splenectomy. G6PD, key things: excellent condition, Mediterranean population. You get increased oxidative damage, so any drugs that are associated with that, sulfa drugs is kind of the classic, some of the antimalarials as well, will cause increase in this oxidative damage, and you get extravascular hemolysis. You get this damaged, clumped up hemoglobin. You can see in these Heinz bodies in here, denatured hemoglobin, and the spleen removes them. So, brief review, you guys learned about the hexose monophosphate shunt, kind of regenerating this glutathione to protect against these oxidants. Look for hemoglobinuria, back pain, and Heinz bodies. And that's it. All right, so that was 3 45-minute chunks, or 3 15-minute chunks, total of 45 minutes. Hopefully this was a little bit helpful for you. And if you have any other questions, let me know. Thanks.